So just a couple of information about the webinar sessions. This is the outline for today's webinar. We will allow you to do some introductions via the chat feature. We are using Zoom, so those of you who are familiar with Zoom, you may be able to use the chat feature as well as the question and answer section if you have any questions for our presenters, and we will have a facilitated discussion at the end of both presentations for you to be able to interact with our presenters and ask your questions there as well. Next slide. This session is being recorded and will be shared on the National Native HIV Network YouTube page. We'd also encourage you to introduce yourselves in the chat box to give your name and the agency you're representing and possibly where you're from. We encourage you to ask questions in the question and answer section as well. And then please complete the evaluation at the end of the session. That will help to inform us of how we're doing, but also of any other information you'd like to share with us as well. So great. And I'm going to go ahead and turn it over to Savannah Jean to go ahead and introduce herself.
Good afternoon or good morning for those of you that are joining us from the islands. My name is Savannah Jean. I am the program director for the STD HIV/AIDS prevention program at the Albuquerque Area Indian Health Board. I also work with the National Native HIV Network, which is the group sponsoring this webinar series. The National Native HIV Network was created in 2017 as a community-led response to increase and also organize a national voice and presence in the HIV movement from the American Indian, Alaska Native, and also our Native Hawaiian relatives. This is supported by the Indian Health Service and also the HIHAF Office of Secretary's Minority HIV/AIDS Fund. And the Albuquerque Area Indian Health Board coordinates a wide array of key stakeholders from the 12 IHS areas to form the National Native HIV Network. The network provides input and guidance to assist IHS and other agencies in efforts to reach high-risk American Indian and Alaska Native populations with HIV testing, prevention, and treatment. We help to build capacity and provide assistance to support extensive community engagement strategies, dissemination of information at regional and national levels, and also support professional and leadership development to sustain these efforts. Our areas are divided into these following regions that you see on this map here. We have regional reps from most of these areas, but we are seeking representatives from California and also our Northern Plains and our Great Lakes regions. So thank you for joining us today, and I look forward to continuing to work with you. So at this time, we are going to start a poll with 4 questions. This is just to give us a sense of where everyone is at. And that will start now. I'll keep that up for a few minutes or a few seconds. Okay, we'll give you a few more seconds here to respond to the poll. All right, I'm going to share the results now. Great, so we have a majority of the agencies that do prescribe PrEP. We have about half of individuals here whose agency has a PrEP Navigator or a similar position. About another 48 plan to prescribe PrEP. And then 100% of you know of a PrEP provider in your area. That's great. Thank you so much. And I am going to stop the share here and hand it back over to Elton.
Thank you, Savannah. I think I got very excited and did not introduce myself at the beginning, but my name is Elton Noswood. I'm currently the co-coordinator of the National Native HIV Network. And so I know many people who are introducing themselves in the chat, so welcome very much. And I was very fortunate enough to have our presenters agree to present with us today around the issue of PrEP and the COVID pandemic. Our first presenter is Dr. Jorge Mera. He is the Director of Infectious Disease at the Cherokee Nation Health Services. He also led the Hep C elimination project that was funded by the CDC and had an overwhelming great response to that project. He's been a great ally in our community and medical provider, so we're very happy that he's able to join us today, knowing that he is a provider for clinics, so we appreciate you being here. So with that said, I will go ahead and give the time over to Dr. Mera.
Thank you, Elton. I'm very happy to be here in this meeting with you all, and thank you for inviting me to share our experience. So I was asked to give a brief overview of PrEP, and then I will continue my presentation. What are we doing with PrEP in the COVID era? I'm very happy to see that the majority of sites are offering PrEP. That's great news, great improvement from previous years. So just a couple of facts that I'm sure you all know, but so we're all on the same page and in context. So the incidence of HIV is greater in certain areas of the United States, and then 52% of the new HIV cases can be tracked down to the southern part of the United States. 67% of the new cases of HIV occur in gay and bisexual people, about 24% in heterosexuals. And unfortunately, injection drug use is also responsible in around 9% of the cases of new HIV infections. And, you know, minorities are disproportionately affected by this pandemic. Let's remind ourselves, we are scared about the COVID pandemic, but we've had a hepatitis C and an HIV pandemic for a long time. In particular, Native Americans from the year of 2012 through 2016 have suffered an increase in the new cases of HIV diagnosis, up to 58%. And when you look at the data in more detail, that increase has occurred across the board from ages 24 to 55, compared to other populations in which it's only in one sector of that population. When we look at lifetime risk of HIV diagnosis by race and ethnicity, unfortunately, I don't have information on Native Americans, but you can see on the left that if you're a man who have sex with men, and you're an African American, your lifetime risk of HIV is about 50%, which is terrible. If you're Hispanic, it's about 25%, and if you're a white person, it's about 8 or 9%. It's still very high. And the people who most need a PrEP are the least, are the ones getting at least. Less than 1% of African Americans that would benefit from PrEP are actually on PrEP. So last year, the Department of Health and Human Services launched the Ending the HIV Epidemic, a plan for America, with their goal of reducing the new cases of HIV by 90% by the year 2030. But when you look at the map on the right, you can see that those counties that are in dark blue, which are 48 counties, and 7 states in the light blue, which is Oklahoma, Arkansas, Alabama, Georgia, Kentucky, Tennessee, and South Carolina, they all bear the greatest burden of new cases of HIV. So the focus of the program was in the first 5 years to deliver more resources to these areas to try to tackle this epidemic. So the epidemic has 4 pillars, which is diagnose, treat those who are infected, prevent infections in those who are not, and a public health response. But today we will be focusing basically on the protect component, which includes PrEP. So every time I am with primary care providers or healthcare personnel, the question I ask them is, ask yourself, how do I fit into the ending the HIV epidemic plan? What is my role here? And if you're a medical provider, the question is, will I be able to find patients at risk? And if I do, will I refer those patients to another person, a pharmacist, to treat to deliver PrEP, or will I try to deliver PrEP myself? So let's not forget that PrEP is just one component of the HIV prevention strategies. Sexual behavioral modification, expanding condom use, testing and treating for sexually transmitted infections, treating patients who already have HIV so you prevent transmission, undetectable equals untransmittable. And then you have PrEP and post-exposure prophylaxis. And last but not least, the implementation of needle and syringe services to prevent transmission in the population who injects drugs. But we're going to focus on one of these 7 components, which is PrEP. So what is PrEP? PrEP is short for pre-exposure prophylaxis and is the use of an antiretroviral medication to prevent the acquisition of HIV in those individuals who are HIV negative. And that acquisition can occur through a sexual contact or through injection drug use. And for this, the FDA has approved 2 medications. Both have basically very similar drugs. They differ in the tenofovir component. One is emtricitabine with tenofovir disoproxil fumarate, which we know as Truvada, and the other one is emtricitabine in combination with tenofovir alafenamide, which is known as Descovy. The second one has some benefits in decreasing long-term toxicity, specifically renal and bone toxicity that the Truvada may have. Now, it's important to remember that PrEP is not a substitution for other HIV prevention interventions that I mentioned, and it does not protect you against other sexually transmitted infections. So we always, promote condom use regardless of if the patient's on PrEP or not. PrEP is very efficacious. When you look at sexual transmission, in those patients who are adherent to the treatment, it's roughly 99% of HIV prevention. And in individuals who inject drugs, depending on the study that you look at, it's about 74 to 84% of prevention of HIV transmission or acquisition. So what are the indications for PrEP? Men who have sex with men who have an HIV positive partner, especially if the partner is not virally suppressed. Recent sexually transmitted infections, particularly syphilis, but it also applies for gonorrhea. And chlamydia, not that chlamydia would be an indication, but it is an indication to do take a sexual history and see if the patient is a candidate for PrEP. Multiple sexual partners, specifically when associated with inconsistent condom use, and commercial sex workers. For heterosexual men and women, the indications are the same, except there's an added high prevalence area component that applies mainly to countries with very high prevalence of HIV. And for individuals who inject drugs, if they have an HIV positive partner who's injecting with them, and if they are sharing equipment, and even though they could be on recovery and on a Suboxone program or methadone or whatever program, but if they're still injecting, they are qualified to receive PrEP. We usually use the cutoff of 6 months if you have injected within the last 6 months and meet these other criteria. And one criteria that is not here, but it's very important, is anybody who comes and requires PrEP, as long as they understand what PrEP is, you have, I would say, even the obligation to deliver PrEP, because they may not be comfortable in disclosing what is their risk, but as long as they understand what are the risks that lead you to HIV infection and what PrEP is, that would be another indication that is not in these guidelines. Contraindications for PrEP is documented HIV infection, if you don't know your HIV status until we can clarify that, or symptoms of acute HIV in the past 30 days. Also, there's a renal clearance requisite, and depends on which drug you're going to use. If you're going to use Truvada, you have to have a GFR that's 60 or above. If you're going to use Descovy, you can use it with GFRs, glomerular filtration rates of 30 or above. So PrEP services usually traditionally encompasses 3 stages. One is the screening stage, when you assess your patients to see if they have a risk for HIV. And if they do, then you have to work them through your clinic process or your health system process. Then you have an initial PrEP evaluation. Second stage is start them on PrEP. And the third stage is to follow them, which occurs every 3 months or every 6 months, depending on what your program looks like. But this is just a standard that can be modified according to your practices. And actually, we today in our system at Cherokee Nation, we try to deliver PrEP on the same day that we are evaluating and deciding that the patient needs PrEP. So what is the role of the primary care provider? What I try to convene is you need to identify patients at risk. And for that, you need to either take a sexual history and take a good history of substance use disorders. If you don't have time, because that's one of the major barriers, is I don't have time to do this because I have patients that have other problems that I need to take care of. Well, if you don't have time, you can offer a brochure before the patient comes into your office, have them read it, a brochure about PrEP, and then when they come in, ask them, did you read the brochure and do you have any questions? And that would be a shortcut if you don't have the time to the sexual history. Then if the patient's at high risk, you discuss the principles of PrEP and what are the benefits and the cons, and then you decide, will I treat this patient or will I refer the patient to either infectious diseases or pharmacy or another provider in your clinic that delivers PrEP. This is the basic history of PrEP evaluation that we use at Cherokee Nation. This is not from any guideline, it's not been validated, but it's a simple questionnaire for those individuals who do not have time to take a full sexual history. We ask them to go through these questions. So the first one is, have you injected drugs in the last 6 months? If the answer is yes, they need a PrEP evaluation. If the answer is no, you go to the next question. Do you have sex with women, men, or both? The answer is no, no need for PrEP. If the answer is yes, you drop down one more. During sex, do you use condoms? If it's all the time, no need for PrEP. Sometimes, go to the next question, never go to the next question. And finally, how many sexual partners do you have? One partner, and they know their HIV status to be negative, no need for PrEP. One or more without knowing their HIV status, that needs a PrEP evaluation. PrEP evaluation does not mean that you're going to get PrEP. It means that you take a deeper dive to see if this patient is a candidate for PrEP or not. But what we tell our provider is just go through this, and if you think the patient needs PrEP evaluation, then you refer them to the PrEP provider, either the pharmacist ID or another colleague that does PrEP, and you basically spend 1 minute or 1 minute and a half just going through these questions. So let's switch gears a little bit to, okay, what has changed with the COVID pandemic? And the basic thing that has changed is the access to patients to our facilities. So the CDC came out with some guidance, and this is just a summary of those guidelines. And the first one is to ensure the availability of PrEP for patients newly initiating PrEP and patients that already are on PrEP and they need to continue using it. They recommend quarterly HIV testing and not to be discontinued. I mean, that's part of the standard of care for patient safety. You can do just lab-on visits, meaning the patient only goes to the facility to get their labs done, and you can do the medical consultation through telemedicine or over the phone. But if it's not safe for the patient to go there or that's not available, consider home HIV testing as another option. The other important pillar is prescribe a 90-day supply of PrEP so they don't run out of it and they maintain adherence. And finally, if you are considering suspending services because of the COVID pandemic, you need to establish a referral site so you can refer those patients to. And if not, ideally you won't suspend the services and you go to an alternative service like telemedicine or a pharmacy-based service. So what have we done in Cherokee Nation? How has this changed us? So we were doing a big HIV and the HIV epidemic campaign addressing testing, PrEP, treatment, etc. So we decided to focus on PrEP since many patients do not come to the facilities for regular visits, so testing came down to a second level. But we would really want to emphasize PrEP. And we shifted our advertisement to digital platforms. We are targeting dating sites, Facebook has been really, so far, one of the best results we've gotten. And believe it or not, people look at the Weather Channel frequently, so we decided to target that too. Then we also wanted specific populations to know that we were offering PrEP services. So we are publishing our ads in the Cherokee Phoenix, which is a paper that 40 or 50,000 Cherokees get in their homes. And remember, we have about 130,000 Native Americans that we serve, so 1/3 get this paper. And also on the Gaily, which is a magazine that is targeted for the gay population. The other thing we did, which I think this is going to be very important, is a texting service that I want to thank, Jessica Leston and their team at the Portland Health Board who helped us set this up. Basically, our advertisement has this number. If you text this number, which is 97779, you will get PrEP information, also a hotline number that you can immediately call one of our providers and get a PrEP provider on your phone. And the other option is they can just request an HIV self-test kit, and we'll mail that to their homes. So this service started picking up lately, and we're putting, a good effort to make this be successful. Finally, education is very important. Before, we were used to delivering face-to-face workshops. Now we decided to stop that because of the COVID pandemic. So first, we want to engage different types of providers. We're not only doing primary care, we're targeting the urgent care, the emergency department. And I just briefly want to mention I had great success there. I have providers starting PrEP on the same day in the emergency room after we gave them the information and the support they needed. We also shifted all our workshops to virtual, and they're done in Zoom. We incorporated PrEP information on our weekly infectious disease echo. And we started right before the pandemic a national IHS PrEP echo. Right now it's on hold, but hopefully we'll be able to resume it when possible. And we have a 24/7 on-call infectious disease provider to manage PrEP calls, and that also has been very useful for the providers and for the patients. So our PrEP intake and management, we rely heavily on our pharmacists. We have a pharmacist cooperative agreement, and they can deliver PrEP once we identify the patient at risk, and they will do the full workup, lab, delivering the medications, and the follow-up. We have a hotline consultation, as I mentioned, callback request from the texting system, virtual visits. The majority of our patients are being seen through telemedicine, and a handful through phone visits. But we give them the option that if they want to come to our facility, we will see them there also. And some do prefer this, but the majority are very happy with the virtual visit. And we have on-site visits 5 days a week available. And that is it. Thank you for your attention, and I will be happy to take any questions if you have any.
Thank you, Dr. Mera, for that presentation. We do have a couple of questions in the chat if you want to answer those, but we will also have time at the end of the presentations to be able to answer those questions as well, so thank you. Our next presenter is Kekoa Kealoha, who is a PrEP navigator and an HIV medical case manager for the Hawaii Island HIV/AIDS Foundation. Kekoa has worked in the HIV prevention field for approximately 4 years and is heavily involved in the statewide efforts to increase HIV prevention and care services for those most affected. He's currently in leadership committee for the statewide PrEP working group, a member of the community planning group focused on zero stigma, and part of EDMAC's Native Hawaiian Constituent Advisory Panel, and as well as the Ke'aha Mahu Transgender Leadership Advisory Group. So thank you, Kekoa, for being able to provide some information on how you are providing PrEP services in Paradise. Look at that, how beautiful.
Hi, good morning, everybody. Thank you so much, Elton and Savannah, for asking me to be a part of this. it's always an honor to be able to share what we do here in Hawaii, and how we do things. You know, we're a small state, but I feel like we collaborate with each other very well, and we overcome very unique barriers to care and to PrEP. So this is super exciting for me. So, okay, let's go ahead and get started. Next slide, please. So first, I'm gonna give you a little bit of background about HIV in Hawaii, just so we can get kind of a clear picture, because when I start talking about PrEP, a lot of what we do with PrEP is really rooted in how we provide HIV care and what that looks like. Next slide, please. So in Hawaii, the way that HIV is kind of distributed throughout the state, the majority of it is concentrated on Oahu in Honolulu County. Second would be the Big Island, the island of Hawaii, which is where I live, followed by Maui County and then Kauai County. Next slide. So as you can see, well, which is not something new, the people who are most disproportionately impacted are men who have sex with men. We do have a relatively low rate of people who contract HIV through injection drug use. And that, you know, we really attribute to the fact that we have the oldest statewide syringe exchange program in the country, which is headed up by the Hawaii Health and Harm Reduction Center. And they have outreach workers in all counties. So definitely a really good presence there. All right, next slide, please. So some of the AIDS service organizations that we have in Hawaii, we have one in each county to serve the different areas. So we have the Hawaii Health and Harm Reduction Center, which serves the island of Oahu. HIHAF, or the Hawaii Island HIV/AIDS Foundation, which is the agency that I work with. We serve the Big Island of Hawaii. There's the Maui AIDS Foundation, which serves Maui County, which is actually a total of 4 islands, 3 islands that are populated, which are Maui, Molokai, and Lanai. And then finally, we have Malama Pono, which serves Kauai County. Next slide. Some other HIV/AIDS programs that we have in Hawaii, we have the Clint Spencer Clinic, which is part of the John A. Burns School of Medicine at the University of Hawaii. The Hawaii AIDS Education and Training Center. We have Gregory House Programs, which is a HOPWA program. Waikiki Health, which is an FQHC, and also Kaiser Permanente. So the reason why I share this is just to really highlight the fact that in Hawaii, we don't do anything without collaboration. Everything that we do, we're all aware of. And what I forgot to put up here actually is our Department of Health, the Harm Reduction Services branch. They are very, very helpful. We have a really tight-knit community in HIV care and prevention in Hawaii. So we have really good working relationships with everyone that allows us to really develop meaningful and impactful programs here in the islands. Next slide, please. All right, so now I'm going to go ahead and talk and share a little bit about our agency, the populations that we serve, and the programs that we have. Next slide. So we serve the island of Hawaii, which is about 4,000 square miles. Our population is about 200,000. The people that we serve are Native Hawaiian, which is me, other Pacific Islanders, which includes like other Polynesians, the Micronesian communities, and other people throughout the Pacific. The Pacific Ocean is a really, really large space that takes up a pretty significant portion of our planet, with a very diverse group of people with various different backgrounds, many, many different languages. We also serve, you know, our white community, Asian community. Hawaii has a very big Asian community, Japanese, Chinese, Filipino, Korean, also Southeast Asians, Thailand, the Thai, Vietnamese, etc. We also do serve to a lesser extent the Latinx community, the Native American community, and the African American community. At HIHAF, we have 3 main branches. So we got our HIV care department, we have our prevention department, and we also have a medical insurance program that allows us to actually sign people up for ACA plans, and also to sign people up for like MedQuest, which is Medicaid in Hawaii, and also to help people sign up and understand different insurance benefits that they may have. For our client population, for people living with HIV, in West Hawaii, we serve 89 clients. In East Hawaii, we serve 170. For PrEP clients, we serve 20 in West Hawaii and 15 in East Hawaii. And for our syringe exchange program, we actually serve about 195 people in West Hawaii. Next slide. So HIV care on Hawaii Island, like a lot of people who provide HIV care services, you know, we've had some time to really kind of, I guess, hammer out our details. So we really identified barriers to care and how to overcome those barriers. So some of the primary barriers to care on Hawaii Island are stigma. Stigma persists. We have a lot of really rural communities where understanding of HIV is very low. And as a result, there is still a lot of prevalent stigma. The cost of healthcare in Hawaii is compounded by the cost of living. Hawaii is a very expensive place to live, and the cost of healthcare can really add to that. We have a very, very, very limited number of medical providers here on Hawaii Island. We actually don't have any HIV specialists in West Hawaii. And the culture of healthcare often results in late-stage HIV diagnoses more often for Native Hawaiians than for other ethnic groups. So Native Hawaiians actually have the highest rate of late-stage HIV diagnoses in the country, which really highlights the importance of early intervention for us and really making efforts to increase access to testing and to other prevention services. So the way that we have addressed these barriers for HIV care by developing programs that address the various needs of people living with HIV. We do a lot of outreach in the community and a lot of outreach with medical providers. And we developed a care medical partnership with the Spencer Clinic in Honolulu, which is what I'm going to talk about today. Next slide. So for PrEP on Hawaii Island, our barriers for PrEP are essentially the same as our barriers to HIV care. You know, the stigma, the low community education, all of these things have carried over from HIV care into HIV prevention. And so for us, it really made sense that we carry out our prevention programs in the same manner that we carry out our HIV care programs. Next slide. So when we developed our PrEP navigation program, we really took a look at our HIV care program and thought, why would we reinvent the wheel? You know, we have something that works, so let's go ahead and stick with that. Next slide, please. As you can notice, I totally took the opportunity to sneak in a bunch of beautiful pictures. Hopefully all of you folks feel like you're at the beach. Okay, so for our PrEP program at HIHAF, in order to develop it, like I said, you know, we don't do anything without collaboration, right? So we developed it in partnership with the Spencer Clinic in Honolulu, and we did it under the guidance of the Hawaii Health and Harm Reduction Center, and they helped us develop our program as a CBER provider. The purpose of this program overall is just to make PrEP accessible for Hawaii Island residents because the number of PrEP providers is significantly restrictive. So what it looks like is the Spencer Clinic provides the medical aspect of PrEP care, and we provide the social support aspect of PrEP care, or kind of like what I like to call case management light. Next slide, please. So when we look at PrEP care and we put it next to our HIV care model, we really follow just exactly the same steps, but they just look a little bit different depending on what we're providing. So in both PrEP and HIV care, we're identifying new clients, we're performing an intake, we direct the client to do lab work, we issue the prescription, we participate in ongoing engagement, eventually the doctor's visit happens, and then we perform retention activities. Next slide. So now I'm gonna go through each of the steps so you can see kind of what we do and what the Spencer Clinic does. So when we are identifying new clients, for our PrEP program, we're looking at HIV testing. We identify a lot of people who would be good candidates for PrEP through our HIV testing program, through referrals that come in from the community, or if the client initiates the referral themselves and contacts us because they want to get started with PrEP. So that's what it looks like at HIHAF, and at the clinical level. They're following a referral from us, or sometimes they get people who are seeking PrEP directly from them, although that is a lot less likely because they are on a different island. Next slide, please. All right, so after we've identified a client or a ideal PrEP candidate, we perform an intake. So what that looks like for us is we do insurance navigation, we do PrEP educational counseling, we have an intake packet that we have the client complete for us, and then we have them fill out the Spencer Clinic intake packet. And if the person does not have insurance, then we also kind of navigate other assistance programs that are available. But I'll go over some of those a little bit later because providing PrEP for people, it's always a different situation for people. So it never looks the same from individual to individual. At that step, the next for the clinic, once they receive the paperwork, they can add the patient to the electronic medical records system. They can schedule a phone intake with the client and then actually perform the intake over the phone, at which point they'll order labs and then schedule an appointment for a visit. So it's important to note too here that, you know, HIHAF, we're on the Big Island. Spencer Clinic is on Oahu, which is on a different island. So all of this right now is happening either through emails, faxes, and phone calls. Next slide. Okay, so once the client has completed the intake with the Spencer Clinic, the next step for them is to go ahead and get some lab work done. So the client will report to the lab, have their blood drawn, lab results get reported to the clinic, after which the clinic will assess and review the review the lab work. And if everything looks good, then they're gonna go ahead and issue the prescription. All right, next slide, please. So after the prescription has been issued, you've probably noticed this so far, the client has not seen the doctor at this point yet. So once the clinic gets the results, if they're satisfied and they feel that the client is able to actually engage in PrEP, they'll go ahead and issue the prescription. We will follow up the client regarding copay if necessary, and then support them however they need it. Next slide, please. Okay, so after the client has been issued their prescription, right now we're focused on engaging with the client and making sure that they're staying in communication with us, because still at this point, they have not actually seen the doctor in person yet. So what we do is we just maintain communication with that person. If they need help kind of troubleshooting adherence issues, then we'll help them with that. And then we stay in touch with the Spencer Clinic just to make sure that we're on top of when the appointment is going to happen for the client. And then when the appointment is set, like 1 week before, we'll go ahead and call the client and let them know that their appointment is coming up. So what's happening at the clinic, if the doctor's appointment is scheduled out for more than 3 months from the time of the intake, they'll have to schedule the client to get labs drawn one more time. Actually, I don't think that I mentioned this earlier, but the doctors from the Spencer Clinic come to the Big Island once a month to see HIV patients and PrEP patients. And so sometimes it is possible for people to not actually see the provider for up to 3 months from the date of their initial phone intake. And if the client has questions or concerns regarding the medication, they are always encouraged to call the clinician, or they can call us. It really depends on the person. Sometimes they want to talk to us because we're much less clinical. We speak the way they do. There's sometimes a little bit of a challenge being upfront and honest with someone, especially if they're very clinical, or if it's on the phone. It's a little bit less personal. And so the role that we play in those situations is we're very non-judgmental. We're there. We're very real people. They can look us in the eye and tell us things that they might not be comfortable telling other people. All right, next slide, please. All right, so the doctor's visit. So once the doctor's visit does happen and that patient gets scheduled to see the provider, when the provider comes to the island and the client comes into the office, so the PrEP navigators here at HIHAF will actually get to look at the client, look at the patient, touch up on how they've been, how things have been going with PrEP, if they have any questions that we can help with, make sure insurance situation hasn't changed, identify any kind of barriers to actually getting the medication. That's what we do. And then the client will actually go and see the doctor. And In which case, you know, the doctor is performing a patient exam, he's reviewing the labs, he's talking about sexual health and sexual practices, and assessing how the client is tolerating the meds, and assess adherence. Next slide. So once that first doctor's visit is done, we're really just looking at this kind of happening every 3 months, ideally, right? The CDC guidelines are that, you know, they get labs done every 3 months. They're tested for HIV every 3 months. It's recommended that they're doing STD testing all throughout those, every 3 months also. So we want to stay in contact with the client, the patient. We want to make sure that they're comfortable with PrEP, that they know that they can come in and get tested with us. The client has the option to get tested at a lab or with us. Either one. We prefer that they come to us just because we like to maintain that communication and that relationship with the client. And then throughout, we're providing adherence support. We're inviting them to different events that we're having. We've had them participate in focus groups, which helps keep them kind of engaged in PrEP care. All right, next slide, please. All right, so for the future of PrEP here at HIHAF, now that we have a medical director, which is extremely exciting, we have a lot more options. I talked about how we have a lack of HIV providers on the island. Our medical provider is going to help us address that issue throughout the whole island. We can use our existing model to expand services. We're looking into more telehealth options for our really rural areas. I know that we're in Hawaii, but sometimes people don't realize like how much land we have to cover, you know. There are parts of this island where cell phone doesn't even reach and you have to drive like 3 hours to get there. And those people need healthcare too. And there's people in those areas who are going to need access to PrEP also. Another exciting thing is that we're actually going to be able to provide PrEP to people without charging for the cost of a visit, which is going to help to eliminate some of the cost barriers that are associated with PrEP. Next slide, please. All right, so I know that I've kind of gone through what our process is here, what it looks like with us and what it looks like with the doctor, but I'm going to talk now a little bit about the role of the PrEP Navigator and why they're kind of crucial in bringing PrEP to people who need it the most. Because there is a really big difference between, you know, what a navigator's role is and what a provider's role is, you know, and we kind of help to, I guess, give the whole pie instead of just pieces of it, you know. Next slide, please. So PrEP navigators should always be compassionate and open-minded. And we've seen this with HIV prevention just in general. When people come in, they're not looking for judgment on some of the behaviors that they have. They're looking for help, you know? And even if somebody is not using condoms and they are unwilling to participate in any prevention methods, it doesn't make them any less deserving of receiving HIV prevention services. So our role as a PrEP navigator is to be compassionate and open-minded with the people who are coming in and trusting us enough to provide them services. A navigator should always meet the client where they are at. You know, some people, where they're at on their journey, it differs from person to person. Some people are perfectly comfortable using condoms all of the time. Some people don't use condoms all the time. Some people don't use condoms any of the time. You know, and it's not our job to try and force specific narratives onto that person. Of course, what we like to do is to give them a comprehensive prevention plan, right? So here's PrEP, and if you use it with condoms, you know, you're really gonna reduce your risk of getting HIV. But we also have to understand that not everybody's gonna be receptive to that message. So our job is to make sure that we identify what a person's ideal sexual life looks like and how we can help them get there. A PrEP navigator should always be supportive of a client's preferred HIV prevention methods. We don't want to yuck somebody's yum, especially if it's effective. Even if there's somebody, for example, who is getting treated for chlamydia 3 times a year, and they're on PrEP, if all they want to do is be on PrEP, we're going to support that. You know, we're going to remind them, of course, how they can reduce their risk, but We're going to support the preferred HIV prevention methods. A navigator should identify clients' unique barriers to PrEP, because as I mentioned, every client's barriers are going to look different. Some people are going to have cost barrier issues. Some people are not going to have insurance. So how do we navigate those situations? Some people have trouble with adherence. So how can we help them to remember to take a pill every day? Some people face stigma and they are, they have a problem with going and picking up a prescription in a local pharmacy. And this all kind of comes with living in a small town, Stigma still really impacts HIV prevention and HIV care where we're at. And finally, a navigator should always be resourceful, thoughtful, and knowledgeable, which means that we need to know our stuff. We need to be mindful of how people are going to interpret that. And we need to be able to find a way to get a person onto PrEP. And sometimes it's being extremely creative. Next slide, please. So cost barriers are usually the #1 barrier to getting PrEP. So for us, we have a unique privilege because we have an insurance program within our agency that allows us to navigate different insurance situations because we have specialists. Insurance is going to be hands down the easiest way to get somebody onto PrEP, but we also have to understand that for whatever reason, people may not be able to get insurance. So how do we help them address cost barriers, especially if they don't have insurance? For providers, sometimes reducing that barrier is partnering with an AIDS service organization or another social service agency that can provide PrEP navigation services. Especially for providers, because we have to understand that providers are already extremely burdened by the amount of patients that they have to deal with. And sometimes they just don't have the capacity to do some of the more nuanced things that AIDS service organizations have the capacity to do. So for providers who are looking to help patients, reduce those cost barriers, my suggestion would be to find a partner who can do all of those little things for you and to share some of that workload. If someone is in a private practice, a provider's in a private practice, if it's possible, consider lowering the rate for PrEP medical services for people who are uninsured. Obviously, this doesn't apply to like FQHCs and all of that, but if it's a possibility, maybe consider it. We should always train staff to help navigate assistance programs if other partnerships are not appropriate or are not possible whatsoever. I know that especially, in North America, that there are providers and, they have radiuses of like hundreds of miles that don't have other people around them who can partner with them. So sometimes it's as simple as having, a nurse or a receptionist being able to navigate an assistance program or signing somebody up for a program to make PrEP affordable. Another way to reduce cost barriers, so medication assistance programs also come with paperwork that requires doctors to sign off on it. So my plea would be to please help complete that necessary paperwork to submit for assistance. And then finally, be mindful of patient needs. I cannot stress this enough. Every patient is different. Their needs are always going to be different. Next slide, please. All right, so identifying means to pay for PrEP patients. So people's financial situations differ, and sometimes they change throughout the year. So a navigator's role is really going to be spending a lot of time focusing on who does not have the financial stability to maintain the same insurance situation throughout the year or able to continue in certain programs throughout the year. So some cost barriers to PrEP include copays for doctor's visits or covering the cash price if the visit is uninsured, copays for lab visits, copays for the drug, and if a person is not insured, they can pay a cash price at a lab or they're going to end up paying full price for a drug. So PrEP typically requires insurance, and identifying an insurance resource to partner with will be incredibly beneficial for the navigation services. So for people who are in AIDS service organizations, if you do not have staff who can sign people up for insurance, my suggestion would be to identify people around you who can help fill that need. The Gilead Advancing Access Program, if you're not familiar with Gilead, they are the pharmaceutical company that manufactures PrEP, both Truvada and Descovy. And they actually have a very good program to help uninsured patients cover the cost of the drug itself. Now, one thing to keep in mind, though, is that program will cover the cost of the medication, but it will not cover the cost of a lab visit, and it will not cover the cost of a provider visit. So the patient is still looking at paying out of pocket to see the doctor or to get their blood drawn. Gilead has a copay assistance card that helps to cover the cost of copays for patients who do have private insurance. So that helps to reduce that small barrier for people who are insured. Unfortunately, that program does not qualify for, Medicaid and Medicare do not qualify for that program. And then finally, the federal government did release the Ready, Set, PrEP program, which does provide PrEP medications for people who lack drug coverage. Unfortunately for that program, it does have the same kind of restrictions that the Gilead Advancing Access program does have itself. So you're still looking at covering cost of the provider visit as well as the labs. I have personally had a lot of experience with the Gilead Advancing Access program. I can tell you from personal experience that it is a very simple program. As long as you are in communication with both the client and the provider, you can actually get that person covered for PrEP very, very quickly. And I'm talking like within a day. It is a very effective program. So if you need help with that, I do have my email at the end and I am happy to walk you through it. Next slide, please. All right, so biomedical HIV prevention finally gave us the tools to get to zero. So I know that, that Dr. Mera shared about the ending the HIV epidemic plan. PrEP is a huge piece of that. And PrEP navigation plays a huge role in helping people to actually access PrEP. Biomedical HIV prevention, we have 2 drugs now for PrEP, which is mind-blowing considering, for a long time, we didn't even have effective treatment. And now we have a way for people to simply take a pill and prevent getting HIV. I know that researchers are trying to develop vaccines. They're trying to develop like a injectable version of PrEP. And as PrEP navigators, we kind of have to be flexible with how we are, how we're learning about these things and how we're talking about them with our communities, because they all look very, very different. But I do have a lot of hope for the future because of that. And I want to thank Dr. Mera for sharing something. He said something that stuck out to me about we have an obligation to deliver PrEP, right? For people who may not be sharing what their risk for HIV is. So we have to make sure they understand, our patients, our clients, we have to make sure they understand what the purpose of PrEP is. And so as an agency, what we do is we make sure that if somebody wants PrEP, they can get PrEP. They need to know all about it, but we're gonna make sure that they get PrEP because we accept that not everyone is gonna tell us why they feel they need it. And that's okay. Not everyone is at the same level of comfort when they're talking about sexual history, sexual health, and things like that. But it's really our job just to make it accessible for the people who are going to need it and for the people who want it. And that is extremely important. Next slide. So thank you very much for letting me share. My contact information is here if you have any questions about what we've done. I do want to point out too that for COVID, because we've already had this program in place, we didn't really have to change very much. We are fortunate to have struggled with finding out how we're going to provide HIV care and prevention to our community without having providers for people to see in person. And that has made it easier for us to adapt to COVID. The only difference is now the doctor hasn't been coming to the island. He's just been doing phone visits or Zoom visits. And physical visits will actually resume hopefully at the end of the year, which is awesome. But I hope that you folks are all staying safe, and thank you very much for letting me be a part of this.
Thank you, Kekoa, for that presentation. The contact information is available for both of our presenters. We did have several questions in the question and answer section. Dr. Mera was able to answer a majority of those questions. We appreciate that. So people want to look at the Q&A section to see his answers on these questions, speaking about PrEP usage amongst trans individuals. Out of 40 patients that they have at Cherokee Nation, 2 identify as transgender women and 1 identifies as a transgender man. I know with the Indian Health Services, there is an implementation for a majority of their clinics to be able to identify trans individuals in their intakes as well. So, you know, that's a positive move in that regard as well. PCP is responsible to educate on how HIV is transmitted. As a PrEP navigator, I find that patients are referred to PCP, including PCP who are prescribing. And then the answer to that is utilizing Zoom workshops to provide those services as well. And then we have 2 questions here. One is, can you share how Hawaii Island HIV/AIDS Foundation has been able to cover the costs of the visits for PrEP patients? Kekoa?
Yeah, sorry, hang on just a second. Yes, absolutely. So when we first launched our PrEP program, we applied for a grant with the Elizabeth Taylor AIDS Foundation, and this was in 2017. So we wrote into the grant to be able to cover the cost of a visit for the cost of a visit and the cost of labs for up to 4 patients, which we were able to do. Unfortunately, in 2018 and 2019, we were unable to provide that same kind of assistance for patients. And so for people who are uninsured, they were still responsible, but we worked out a lower price with the Spencer Clinic to be able to provide PrEP for people who are uninsured. And so it actually cut the visit rate in half, which made it a little bit more accessible. And then for labs, if the client was going in and paying upfront, it was about 50% less than if they were being billed for it after. So we just had to coach the client into paying upfront for the labs, as well as working kind of that back deal with the Spencer Clinic to lower the price. But now, with our provider who is in-house, he has actually seen 4 PrEP patients and not had to charge for that. So he is providing that service free to people because it's a way for us to eliminate the cost barrier. And because we have the privilege of being able to do that, that we don't rely on that visit to help us run our facility. So we're able to provide that as a free service for the patients. And I would like, if it's okay, I would like to add on to the question about PrEP use within the trans community, because there's a couple of things I think that are super important to mention about HIV in the trans community. One, HIV data has a really bad history and a bad habit of misgendering our trans community members and their risk profile. And so in the past, a lot of it has been documented. It's, for example, like male-to-male contact, which is inappropriate, especially if we're trying to consider actual gender identity. And if we're trying to get realistic data for the trans community, that actually does more harm than it does good. Also for the trans community who are of color are more disproportionately impacted by HIV than trans people who are not of color. And then, of course, the trans community just in general is more disproportionately impacted by HIV. So as far as PrEP use goes to the trans community, they need it the most. However, they are more burdened also by poverty, which makes PrEP access a little bit less realistic. So I don't have like concrete numbers for that, but I can tell you that the need is there and that efforts need to be significantly increased.
Okay, thank you, Kekoa. You know, and knowing that PrEP access, you know, particularly in Indian Health Services Clinic, can be done because now PrEP medication is on the Indian Health Services formulary. So if your clients are accessing Indian Health Services services, I guess that's a double negative or a double positive, then they should be able to access that, you know, with that regard. So just closing up this session, the final question is, how has COVID changed PrEP navigation? Do you have Zoom sessions? I know, Kekoa, you mentioned telemedicine, but Dr. Mera, do you want to answer that a little bit?
On navigation, telemedicine for PrEP navigators.
Yeah, or just services in general, you know.
I would leave that specific one to Kekoa, but in general, yes, we've been using telemedicine. I would say 90% for PrEP patients and 80% for all the rest of the other patients. We do give them the option to come to the clinic if they wish and prefer that encounter, and some do. And, you know, we can see them in the clinic, but it has basically switched to telemedicine. And many of I would say that half of the one who are engaged in telemedicine, I think they will want to stay in telemedicine. It's more comfortable for them to make the appointments, and we can change the appointments. If they need to change the time, it's easier. The lab part is the only component. Someone asked about the OraQuick HIV at home. It does have less sensitivity. So we ask our patients if they can come to the lab, it's better. But if they cannot, we respect that decision. And we prefer to do a less sensitive test and not have them drop out of PrEP. But we don't have, you know, that big volume of data yet to say it's how safe it is or not.
Okay, great, thank you. Kekoa, you have anything to add?
Yeah, sure. I mean, kind of like I mentioned, we do a lot of Zoom, a lot of telephone calls. We have been able to open somewhat. We've been able to take like appointments in our office since the beginning of June, but we have to go through a screening process, which makes it a little bit, you know, looks different. But a lot of navigation and counseling happens over the phone or over Zoom.
Okay, thank you. And then we have one question here. When asking the screening question of who someone likes to have sex with, should we include transgender person in that screening question?
Yeah, that's a great point, and we should. It slipped when we were generating that questionnaire, but it should be included. Thank you for
absolutely. I also think there needs to be a concerted effort with data collection at the federal level, because a lot of like state departments, for example, are collecting information based off of federal guidelines. And so like forms we use for HIV testing, for example, don't break down risk appropriately. So I think that the way we collect data has to be completely overhauled, especially to include trans care.
You know, and I'm seeing a movement more so, you know, at the local level or agency level as well to be able to provide that. I know there are some transgender capacity building programs that are out there nationally that can be able to assist with that. Miss Maddie Jim is obviously one of those national advocates that can help to provide that information as well. It was also mentioned that at the International AIDS Conference, they had several presentations on PrEP for transgender populations. So if people still have access to the International AIDS Conference, it might be a good thing to look at. You know, in terms of our evaluations, which I'm going to encourage all our participants to do, maybe you can ask for a specific webinar on transgender health that we could also provide with you, so we could address those questions more specifically. I want to be cognizant of people's time. I know we're over the 1 hour limit for this webinar, but I want to say thank you to both of our presenters for taking time out of their day and the services that they're providing to present us on PrEP, you know, for providers, access to PrEP, you know, medical advice in the clinics about PrEP. So thank you both for taking the time to do that and supporting the National Native HIV Network. Thank you all for participating in this webinar. Again, there will be an evaluation that will be sent to you. Feel free to fill that out. And then just a reminder, our next webinar will be taking place on August 27th around the topic of harm reduction during the COVID pandemic. So we are going to begin to organize that. So we'll send out that information as well. Okay, thank you, Dr. Mera, and thank you, Kekoa, for both participating on this webinar. And we hope everyone has a good rest of the day and month, and stay safe out there, wear your mask, wash your hands, and social distance. Thank you.
Thank you, everyone.
Thank you, guys. Have a good one.